We have former Deputy President Rigathi Gachagua, who hopefully is feeling a bit better, and he's been watching our conversations on KTN this morning, or just following our conversations on YouTube and Facebook. Asante sana, we appreciate you. We wish you all the best, Baba Gachagua, and we also wish all the best to Mama Dorcas. As these things happen. Ni hali tu ya maisha. Don't worry, even this shall pass. This too
shall pass.
It's what happens. So we've had that conversation, and now we wait to see what happens now. 14 days within which the president shall nominate a new deputy president, and that name shall go to parliament. And just like we've heard from the lawyers who wrote the constitution, there is no expectation for any vetting that is to take place in parliament. It's just a vote. Honorable members, I have received communication from His Excellency the President, who has nominated CT Muga as our new deputy president. We shall go into a vote. Acclamation. Will as many as have similar opinion, and that's it. And CT will go to Kasarani and CT Muga, do swear. No, let's repeat that. I shall continue. Let's repeat do swear. To serve. Okay. I hope we are not going to have that kind of drama again in Kasarani with this incoming deputy president. Our Health Friday conversation today and this week is on a matter that we haven't really discussed much when I do our Health Friday conversations: ear, nose, and throat, ENT. So we hear the ENT doctors. What do they look at? Ni wale wa kuangalia kama masikio yako iko na wax.
Kama mdomo wako iko na meno.
Kama mapua yako ni kubwa.
Yes. Ama macho yako pia ni kubwa.
Yeah. Right? So we have then invited our consultant ENT specialist to come and join us, Dr. Wahome Karanja. Good morning, Dr.
Good morning, Latiff. Good morning, City.
How are you?
Very well, thank you.
Mm-hmm.
And it's a great pleasure to be here this morning in Spice FM.
Karibu. That's the hot seat of the Situation Room. Okay. How does it feel?
Well, it feels okay. But I think it's about to get hotter. So
the guy who was sitting there before you is a PhD from Warwick University.
Correct.
And has written constitutions. He writes constitutions like someone sells mboga.
Correct.
Mama mboga akiuza sukuma.
Anaandikia
constitution, katiba, Liberia, what,
Correct.
So you're in a good place.
Asante.
Good space.
Yeah, thank you.
You'll tell us what an ENT specialist is and what they do. You see, City has mentioned eyes. Does ENT cover eye as well? Is it the whole face, or is it just ear, nose, and throat? And what's the connection between those? All right, and so on and so forth.
Correct.
City, this week, Daktari, City goes to an African country every week. He mines proverbs from that country, and he comes and gives us a proverb. Now, the job of our guest is to listen to the proverb, think about it, and give us your interpretation of that proverb. So this week, City, you've been in the People's Democratic Republic
of Algeria. Next week, I will be in Tunisia.
Yeah.
Yes.
The Maghreb countries.
It's a Maghreb country.
Okay.
Yes. Today's proverb is a fairly simple, straightforward one. The absent always has a justification.
The absent always has a justification.
So my interpretation, right?
Yes.
Okay. Okay. So I think from the look of it, it's basically, I think, a sharp analysis of human nature. That we will tend to, if we are late or we are absent from something that is required of us, come up with a way, either creative or imagined or real, of why we were absent. But on the witty side of things, you can imagine that when I am absent, then I hold some temporal power, because then I'm leaving you to speculate on why I'm absent. And then I'm also being given time to create a story around what my absence was, whether true or imagined. But interestingly, I want to add that, did you know that Kenya also is second in terms of the Numbeo listing in Africa as having the best healthcare system? Second to South Africa. And third, I think, is Algeria, and fourth is Tunisia. So maybe there's some relationship.
Kenya is second.
Correct.
In Africa.
Correct.
In terms of the best healthcare system.
Correct.
So this noise we make Because there's system and then there's practice.
Correct.
The utilization of that particular system.
Yeah.
But we're talking system.
System.
Okay. Baba.
Yeah.
System.
System yetu sawa.
System iko sawa.
Okay.
So I think a little bit of hope there.
No, a lot of hope.
A lot of hope. No, it's a lot of things to celebrate.
Yes.
And just making sure that then we utilize this system and continue building on it.
Absolutely.
Dr. Wahome, what's an ENT specialist?
So an ENT specialist is a qualified medical doctor who has further trained in matters specific to the ear, nose and throat. Lots of times we are also understood to manage areas that are adjacent to where we manage, which is eyes. And that's the domain of the ophthalmologist or the eye specialist. And also dental, which is the teeth, the jaws. So generally, ear, nose and throat patients, doctors would manage conditions of those areas and the head and neck region, commonly areas like the thyroid gland and so on.
Okay.
Yeah.
So you went to school first. You did a degree in medicine and surgery.
Correct.
How many years?
6 years.
6 years.
Yes.
You went through internship for a year.
Correct.
You then worked for 2-3 years.
Correct.
Before you qualified to go now for a master's.
A master's in ear, nose and throat surgery.
So
Correct.
then you went for a master's in ear, nose and throat. How many years?
4 years.
Okay. So 6 years plus 1 year plus 3 years. Hizo ni miaka ngapi so far sitting? Kumi.
Kumi.
Okay. Plus another how many years now?
4 years.
4 years.
Yes.
So after 14 years, that's when you become an ENT specialist.
Generally, yes.
Okay.
Kuna masomo mengine unaweza kusoma.
Okay. So when we talk about ear, nose, and throat, right? There are people who just assume why those three? Why are they interconnected? Why do they come together?
Because they are interconnected both anatomically, in terms of proximity to one another, and the conditions that affect one region would generally also be transferable to the other. So when you manage them, when you look at that region in its totality, the ear, nose and throat and the head and neck, then you're better able to manage those conditions. Case in point is in children. 5 out of 6 children would have an ear infection below the age of 3 per year. And when you have ear infections, you tend to also come down with cases of throat infections like tonsillitis. And you may also have breathing problems associated with also poor sleep and concentration. So these children with hearing loss or hearing disability are also not concentrating in school properly, are also having a poorer quality of life. And so I think the wisdom is to manage that area in totality. So it's more holistic to look at that region in that specialty.
5 out
together.
of 6 children under 3 will have an ear infection
In a year.
in a
Every
year.
year, yes.
What brings this about?
So lots of things. One of them is that that region is poorly developed. So there is a drainage from the ear to the back of the nose through what is called a eustachian tube. And that drainage mechanism is poorly developed. And therefore, they are more likely or at risk of developing ear infections.
When you say poorly developed, what do you mean?
They're still undergoing development, so shorter and wider. So when you have a throat infection, for example, or a sinus infection, in those children, they're more likely to have that infection going over to the ear and causing problems there.
Can it be avoided?
Yes, it can be avoided, but I think the more important thing is to be detected early and treated properly. Yes, but there are risk factors to these conditions. For example, overcrowding, early schooling, interaction with persons who have infections, better practices of hygiene, for example. So you have children who start early schooling, suffering these conditions more frequently than those who go to school later.
Okay. Now, what's the worst that can happen when you get an ear infection?
So most times when a child has an ear infection, they'll tug at the ear. And ear infections tend to be painful, so they will cry. And many times the parent has not slept by the time they're walking into your office also when they bring in a child. So everyone in the house does not sleep. So they're uncomfortable, they're in pain. Oftentimes it begins with a viral infection, and these are self-limiting. So your painkillers would be able to relieve a lot of those symptoms, lots of fluids and so on. But when it progresses more and perhaps becomes a bacterial infection and lasts longer, you may find that you need to institute an antibiotic. Now, if those things do not happen, the worst case scenario is that ear infection can become chronic. In other words, it can last longer than the usual duration, where you can have, for example, a rupture of the eardrum and pus or fluid draining out of the ear. And over time, this can also lead to hearing loss.
Over time.
There are those who may not have that pus draining or fluid draining out, but there is a buildup of that fluid in the middle ear, what is called otitis media with effusion. Now, in these children, you'll begin to realize that their hearing is impaired. So they need higher volumes. They will struggle in concentrating in class. They will not listen to instructions. Now, you can imagine the flip side. The teacher thinks that a child is not attentive,
Playing truant.
or truant, and they can be punished when in the real sense they are not hearing.
They actually can't hear.
Yeah, and therefore obviously learning is impaired. And in this very early age of childhood learning, you can imagine we need all the input from either visual or hearing stimulation. So if you miss out on that very important foundational aspect, it can have long-term effects on learning and development.
Okay.
Correct.
So if I'm hearing you right, you're saying many of the hearing losses that happen with children will have started with an infection.
Correct.
Is there any other thing that can lead to hearing loss of a child?
Absolutely. There are many reasons for hearing loss, one of which is congenital. You can have hearing loss that exists within families. If you come from a family where you have relatives who have had hearing loss, then you are at risk. Childhood infections outside of even ear disease can cause hearing loss. Meningitis, for example, severe infections. Medications that are used to treat these infections, some of them can be toxic to the ear and reduce the ability to hear. Yes, so there are those causes. Trauma, for example, can lead to hearing loss. But the most common tends to be middle ear infections.
And then how can you detect this early? As a parent, that you have a child there and the child is growing and developing. They got a ear infection 2 years ago when the child was 1, and now they are 3, they are still developing. How can you detect hearing loss? Is there a way in which you can start noticing, or you can tell that your child is on that verge of hearing loss?
Yes, so the subtle signs will be that if they are using devices, for example, the television or radio, they'll tend to raise the volume, or if they're using your mobile phone, they'll do the same. And they would ask you to repeat. And or when you speak to them, you'll realize that you need to raise your volume, or oftentimes they're not responding immediately. Once you have those telltale signs of somebody who's struggling to hear, then it is time to seek help and perhaps have their hearing checked.
Can it be corrected?
Yes, majority of this fortunately is correctable, either through medications, through or through some procedures, medical or surgical procedures.
ENT. We look at the E and then N.
The nose.
Yes, this season that we are in, both Eric and I have had problems with a cough that doesn't seem to go away, and an irritation that doesn't seem to go. So we've actually been asking
And
ourselves.
for me, voice loss.
Yeah, he actually lost. I mean, historically, he lost his voice. He had to look after it and talk. Yes, which means I had to talk more.
Yeah. Okay. Exactly. Yeah.
What is it that would bring about something which, one, if you go for if you go for a checkup or if you go to get treatment, nothing is actually found. There's actually nothing wrong with you, and yet you still have the irritation and you still cough.
Correct.
What brings about such things? Is it the weather? Is it the season? Is it a sign that the things that we have an allergy towards? What is it?
Okay, so that's the ear, the nose and the throat.
Yes. Yes.
So again, silent things. So throat infections. one of the things that would make you need to see an ENT specifically, or even a doctor, is if it is progressive. If you have a voice loss that's lasting well over a week, in Eric's case, more than 2 days would be tough, because if he's a professional voice user, yeah, 1 day is a lot. Professional voice users, that's a challenge. Yourselves, teachers, politicians, people who need to speak for a living, musicians, yeah. So we take care of those. So if you're having a problem with your voice, where you're having to clear your voice constantly, or you're having a sore throat, most of these will be treated with home remedies. So the first thing is voice rest. Do not strain a voice that's already straining. Again, I don't know if you are aware that when you whisper because of a sore throat, you actually damage the voice even further. Yes. So the recommendation is, if you are really straining, stop speaking.
Shut up.
Yeah.
Completely.
And take plenty of fluids, because a lot of water would be able to help. There are also these home remedies with turmeric, garlic, and that help just to rehydrate. And that rest will reduce or relieve the edema or the swelling that's around the vocal cords that produce sound or voice. And generally that would go away. But if you're having persistence of more than a week, or it's progressive, meaning it's worsening and yet you've treated it, or it's recurrent, more times than usual, and yet you are exercising what is called good proper voice hygiene. What that means is, you're not straining when you speak, you're not whispering when your voice is going, and you're not shouting or screaming, meaning you're damaging your vocal cords. If you are practicing all those things and lubricating well by taking enough fluids, then you need to seek help. And typically would examine, listen to your story, and there's at least good equipment that we can be able to help visualize and see what the change that you're experiencing could be coming from. Maybe you have acidity or reflux issues that are causing a strain or damage to the vocal cord area, and by treating that, then we'll be able to give you help. When it comes to the nose, CT, and you've talked about the season where you find yourself having sore throats, perhaps sneezing a lot, the things that could cause is either what we are ingesting or what the environment is, like environmental pollutants. And depending on where you live or the situation in the place where you spend most times, or your home, if you have allergies, for example, you may need to have a look at that environment and alter it. If you find that when you walk into your house, you have a sore throat or you sneeze, or these symptoms are magnified there could be something within that environment. Commonly, it could be dust, or what you call house dust mites, or even mold. If you're having leakage in the wet areas, the kitchens and the bathrooms, that has some mold, the spores within that mold could be triggering some of these things. So when you think through it, and perhaps you even find medical help, then either a change, including a paint job, correcting plumbing, changing the kind of sheets that you use, dusting more, vacuuming, those are the things that can be very useful. And of course, lots of fluids and rest as well.
Okay. A couple of questions coming in, and of course we'll be taking many more of them. Steve Oma says, Dr. you have a kid who is 6 months now, and there's one issue that I've noticed in him, and it bothers me a lot. The issue at night, he normally breathes as if he has a blocked nose, like mtu ako na homa at night.
Okay.
What could that be?
So a stuffy nose is not uncommon in children. And by the way, children are not small adults. There is a lot more complexity that seriously, there's more complexity. If you shrink City, he will not be City when he was 5. A lot more changes physiologically and in individual spaces within a human being as they transition into adolescence and adulthood. So they are a whole ball game. Now, it is not uncommon for children, even at the age of 6, to have a stuffy nose. But again, if it persists longer than 2 weeks, they are not unwell, they are feeding properly, then you want to find out, why are they stuffy? It could be allergies, and like the things we've alluded to, if they're sneezing, if they are itching, then perhaps you want to control that. Sometimes you might need medications, like anti-allergy medications, to control it. Later on, between the age of 6 and, say, 3 years, if your child has a stuffy nose, is snoring and mouth breathing, and the snore is loud, children are not supposed to snore, except when they have an upper respiratory infection, which we say is pretty frequent in these children in early learning phase. So if that is persisting despite them being in perfectly good health, then you may need to have an evaluation to find out, is there something physical going on with them? And one of the common things that happen in children is called adenoids, or adenoid enlargement. So adenoids are tissues along with tonsils, or rather they are similar to tonsil tissues, but they are found at the back of the nose. Everyone develops adenoids from as early as 6 months of age, but they hardly cause any problems. But there are those for whom the adenoids overgrow and occupy that space within the nose cavity, and they will lead now to those signs of obstruction, which is snoring or loud snoring and breathing difficulty. So your child is waking up, crying at night, looking for positions of comfort when they are asleep. You may need to have that investigated and treated.
Are adenoids different from sinuses?
Yes, they are.
What's the difference?
So sinuses are air-filled cavities in our skulls, and just to progress the discussion on why children and adults are children are just not small adults. The three of us have fully formed sinuses. Children do not, and they form at different phases. So our skulls have these air-filled cavities that continue into the nose, and their work is basically to help also produce mucus that is protective in the nose. They also give us our typical voice. That's why when you have a cold, somebody says that you sound stuffy, or you have what is called a hyponasal speech. Now, sinuses can get infected, and that is what is called sinusitis. And one of the common things we hear when people visit us in the clinic is, I have sinuses.
Yes.
So the first thing you have to do is to tell them,
of course,
then I'm proud of you, or I'm happy about it. Because yes, you should have sinuses, just like you would have hair. So, but adenoids in children are actually the commonest cause, especially in children below 6, for recurrent sinus infection. So if your child is having a recurrent stuffy nose, including maybe the one who spoke about their 6-month child. So if you're having a stuffy nose, recurrent, what is called a postnasal drip, cough, maybe a bad breath, then the adenoids could be the source of sinus infection. And treating them could treat also the recurrence of the sinusitis.
Okay. There's a question here. My dad has a hearing problem that is getting worse with time. My grandfather had the same challenge. What could be the cause of this?
Okay. So remember we spoke about hearing loss also running in families.
Yes.
But there is a condition of age-related hearing loss. And this one, many people will not escape. Beyond the age of 60, in fact, we recommend that it would be wise to seek a hearing consult. Hearing, just like vision.
Suchi, please repeat. Beyond the age of 60.
I was not sending any
message.
message.
You see the need?
Yes, I see the need. So beyond the age of 60, it would be wise or prudent for anyone to have their hearing checked.
Can you repeat what you just said again?
Beyond the age of 60. So first client for the week next week, CT. Yes. So
Why?
And so first of all, hearing is a silent disease. It's difficult to tell that somebody has no hearing. Well, it's very quick to see somebody who is not visualizing, but hearing is very important along with hearing to help us appreciate our environment. Hearing actually even gives you what is called visual imagery. If you're crossing a street and you hear a motorbike coming behind you, your brain immediately starts to process that there is this that you expect. If you hear a truck, then you know that I'll probably you manage your reactions because of hearing. So it's very, very critical. Now, as you grow older, the cochlea, which is the organ of hearing that is responsible for that sensation, ages as well. And that can lead to age-related hearing loss. So you start raising the volume. You start sort of struggling in social interactions to hear what your neighbor is saying. So that's what typically happens. Now, if it gets to a point where you are withdrawing, you certainly need a hearing test done. So for the caller, it's very important for his father to have a hearing test done. This is usually done by the ENTs along with our audiologists, where we do a hearing test. And that hearing test is non-invasive, very quick, and we are able in a short space of time to be able to determine, does he actually have a hearing loss, and what is the kind of hearing loss that he has, and what is the degree of hearing loss. If it's mild, then we give advice and we say, these are the things that you can do in terms of modification, altering your hearing environment so that you can be able to appreciate a lot more. If it's moderate or severe, which means that you are really struggling, even in one-on-one situations, perhaps there are things that we could do to help improve that hearing. Now, if it is the cochlea, which is the end organ of hearing that is involved, we cannot restore that hearing. All we can do is aid it. And so that is where hearing aids come in, where we can prescribe devices that are able to program that hearing to be raised to the level of normal hearing, and you can be able to reconnect with the environment.
I've had issues with my throat producing phlegm abnormally for a month. Now, what could be the problem? What advice would you give?
So again, not uncommon. So if you're having phlegm, is there pain associated with that or not? So that would be a good question to ask. What's the diet? Are they having symptoms of irritation, what you might call reflux symptoms as well? Because that might be what is causing the problem. Some people have some allergies or problems with certain foodstuffs, certain nuts, milk allergies, gluten, and so on. And avoiding some of these things in the diet, restricting them, might be able to change the quality of that mucus being produced or saliva being produced, and perhaps allow the phlegm to go away. Gargling, but generally good oral and dental hygiene will help a lot of these problems go away. But when it progresses further, and then now you're having problems of swallowing, perhaps your voice is changing, it might be a time to get checked, because 1 month is a long time.
Where does the throat begin and where does it end?
Okay. So the throat begins at the back of the tongue.
Where is the back of the tongue?
And the back of the tongue is where, if you imagine sticking your finger in, and you would feel like choking, or where the toothbrush ends up going when you're brushing your tongue. So that would be the beginning of the throat, or what is called the pharynx. And it continues towards the back, and it's a 3-dimensional space, because then it's interacting with the back, with the roof, which is the nose, the nose cavity, and progressing further down, where now it branches into 2 areas, which is the airway, or the larynx, or the voice box, and the food passage, where there's a small tight area called a sphincter that's supposed to remain closed until you're swallowing. But we're always swallowing. We're building up saliva. We're also swallowing mucus from the nose every few minutes. That's passing through this sphincter. So that's the throat area. So when somebody, for example, that's a fantastic question. When somebody says, I have throat cancer, it could be in the area of the larynx, which is the voice box, and typically then that person would have voice changes. Or it could be at the area of the oropharynx, or the beginning of the food pipe, which typically means swallowing is a problem. So you have progressive difficulty in swallowing. So you have struggled with meat, then after a month you're struggling even with ugali, and then after a month now you're struggling with porridge. That progressive struggling with swallowing is an ominous sign that there could be something occupying that space, that could be a growth in that area.
Throat cancer, you mentioned.
Correct.
So go there. What's that?
So throat cancer means an abnormality in that area of the throat that I've talked about, which is the pharynx, which could be the oropharynx, it could be the laryngopharynx, or the larynx itself. So any of those areas there, you can have an abnormal cell growth that leads to symptoms. Unchecked or untreated, of course, then it can be able to spread. And throat cancer is actually one of the leading cancers among the head and neck cancers, even in our region, predominantly because of the risk of cigarette smoking. A little bit of environmental risk as well, small portion of genetic as well. But one of the important things about throat cancer to note is caught early, it's also highly treatable. One of the most highly treatable cancers you can get.
So what kind of screening do you do for throat cancer?
I wish we had a typical screening for throat cancer, the same way we could do for women with pap smears and so on. But it doesn't exist because of the sort of semi-invasive nature of that. But the best thing would be just education education of voice and the things to note. If your voice has changed and is progressive over a month, you need to be screened. If you're struggling to swallow and you have a feeling of a lump in the throat when you swallow and it has lasted at least a month, you need to be screened. And what would that screening be? It would involve, of course, the physical examination. Sometimes we have tools and instruments that look into those areas. And should we find a growth, then we're able to biopsy that growth, and that will be able to give us a result of whether you have a cancer or not.
Okay. And the throat cancer is different from esophageal cancer?
Correct.
Why? How?
Because the esophagus begins below the throat, from that area of the sphincter that goes, but you can have, because the esophagus is a long tube, you can have an esophageal cancer that's
close
at
to
the top.
the throat.
Yeah, so maybe coming from the throat and going into the esophagus, or the esophagus going up to the throat. So that you'll find that we will manage that collaboratively with the people who are called cardiothoracic surgeons. Then you can have mid and lower esophageal cancers, and that lower esophageal cancer can also go to the stomach and become and involve what is called gastric cancer. So the body is interesting and complex.
No, the body is very interesting, which gets me to, we hear of throat cancer. Why don't we hear of ear cancer?
It is there, but the incidence is not as much as the throat.
How come? And they're connected.
I think it has something to do with even the blood supply to that ear area. And also the interaction of irritants that would cause throat cancer. So typically, the commonest causes of these throat cancers are things that we consume. So if you're chewing tobacco, then you are at a high risk of oral cancers of the tongue and that area. And even at the back, if you're smoking tobacco, then you're at a higher, very increased risk, especially if you also do it at the same time with alcohol consumption, because these irritants are constantly in that region irritating, and therefore they cause the changes in the cells that bring up cancer. But the ear is different. You don't have a lot of those irritants going into the ear. We're not pouring things going in there. And so we do not have that high incidence of ear disease. But overall, ear disease is still a huge contributor to our well-being, because hearing loss, drainage of ears, ear pain, and so on, those are things that cause a significant reduction in quality of life.
In Kenya, as an ENT, what would you say are the commonest cancers within the sphere that you're a specialist in?
Yeah, so throat cancer tops the list.
Kabisa.
And laryngeal cancer, correct? Yes. And then the head and neck cancers. So from the if you leave the region of the throat, then you talk about salivary gland tumors, parotid gland, submandibular glands. These are the glands that are found around the head and neck region. To imagine, the parotid is a gland that's found in front of your ears. It's the one that, when enlarged in children, you say they have mumps. And then the submandibular is just found below the jaw. Sometimes it's mistaken for lymph nodes. Again, that is in terms of reducing incidence from the laryngeal cancers. And then, of course, the thyroid gland itself, which is found at the bottom of the neck, before the chest, at the front. Again, leading cause, but more common in women than in men.
Do you find in your experience that these cancers are at an increase in the country?
Yes, they are.
Now this is age group, gender,
Demographic.
Yes, exactly.
So the demographic is generally in those who are above the age of 40, perhaps because they have had a longer interaction with the environmental irritants, pollutants, and so on. And of course, carcinogens, the things that cause cancers that we consume. So you have a higher incidence in people above the age of 40 and a much higher incidence in those who are above 60. In terms of women, where there is a little bit of a difference, is thyroid tumors. So majority of thyroid swellings are benign, but there are those among them which can either start as cancers or transform to become cancer. So in this demographic, you find more women. And so there is a correlation between the gender of women and thyroid disease, so to speak.
I would explain that thyroid story. What are thyroids and what do they do? What's their importance in the body?
Okay, so the thyroid gland is found at the front of the neck. It's what you call a shield-shaped organ. You don't feel it unless it's enlarged. So when you look at somebody who has a swollen neck or a swollen bulge on the neck, most times you'll say they have a thyroid enlargement or they have a goiter. Now that thyroid gland is very useful in producing what is called thyroid hormone that allows us to balance our consumption of energy or glucose for the body. Now, if you have excessive hormone production, then you're also consuming much more. So you get symptoms that include maybe a rise in blood pressure. If you have a reduced thyroid hormone production, then basal metabolism is also lowered. So you find lack of energy, hair changes, and so on. But you can still have a large thyroid without a change in the concentration of the hormone. So you're called euthyroid. So regardless of whether it is raised, normal, or reduced, any thyroid enlargement requires further investigation. So we may need to have a look, examine. There are imaging investigations like ultrasound we could do that tell us what component of the thyroid is enlarged. Is it both thyroid lobes that are enlarged? How deep is it going? So in terms of size. And then also a little bit of a needle stick from that thyroid to tell us what are the cells of the thyroid. Are we talking about a benign thyroid swelling or an enlarged or a cancerous thyroid swelling? Because that then allows us to know what kind of surgery, for example, if that's the step we'll take, that we will need, and also other managements around the surgery. And of course, the thyroid hormone tests, which are blood tests that determine whether you have normal or abnormal thyroid hormone production.
Do you remove thyroids?
Yes.
At some point.
Correct.
Now, are there effects to someone who has no thyroid? I've heard about hormonal imbalance, mood
Correct.
swings, and such kind of things. Is it?
Fortunately, outside of the so ideally, when you remove the thyroid, you could remove it in part or in whole. If you're talking about a cancer, most times you'll have the entire thyroid gland removed. And the reason for that is obviously because then you do not want to have the risk of spread and followed by some level of treatment thereafter. If you have, say, one thyroid lobe that is markedly enlarged, you can remove that and spare the other one. This spared one will likely take up the work of producing enough thyroid hormone for your body's needs. So you'll be fine. But when you have a total thyroid removal, it means you're no longer producing thyroid hormone, which is very critical for your body's function, in which case then you will need hormonal supplements of thyroxine. Fortunately, it's readily available in any corner of this country, and it's also very fairly priced. So in terms of long term, for somebody who is no longer producing thyroid hormone, but required a total thyroid removal, then survival, quality of life is pretty fantastic.
Pretty much the same.
Pretty much the same. Yes.
Okay. There's something that I don't know whether it still happens, but it used to happen a lot when we were growing up. Kids are taken to this guy who puts a spoon in there and comes with a makasi and they cut kathing
Kilimi.
at the back of the throat.
Correct.
Right?
Yes.
What's that? What are they cutting and why?
So that cutting there is called the uvula or kilimi. And it's a traditional
Uvula
practice.
is an English name.
Yes, uvula.
It is not uvula. It's not Kiluya.
No, it is not. It's actually the uvula. It's a thing that hangs. If you look at a cartoon character who has opened their mouth, and you see the thing that's dangling.
Yes.
But it's very important.
What does it do?
So it's part of what is called the soft palate or the pharynx. Yeah, the nasal. It is part of what is called the soft palate or the end of the soft palate. It moves. So when you swallow, if you imagine that it's hanging there, it'll actually move backwards and prevent regurgitation. If I removed your soft palate and you swallowed water, some of it would come through your nose because then that area is not being blocked by that uvula falling backwards. So anyway, traditionally, by the way, as ENTs, if I look into your throat and I listen to how you speak, I can almost tell where you come from if you don't have an uvula. Yeah, because there are subsets within our communities who still practice ovulectomy. We discourage it a lot for a few reasons. There has been obviously incidents of people who have had an ovulectomy and have literally bled to death because they had a bleeding disorder. So it's a risky thing for some people, but it's still carried out, unfortunately. We feel it has really no medical value except in very, very few select cases. The belief used to be that when you cut it, you will reduce the incidence of homers in children, the constant cough that they get. It's hardly involved in those kind of things.
So now that we lost it, I was taken.
Okay.
Then I was given soda.
Yeah.
To relax.
Correct.
It has to be very early in the morning.
Yeah.
Because of the bleeding, I believe.
Correct.
So now that we don't have it, so what do we lose? What don't we?
You haven't lost much. It's useful, but it's also vestigial at the same time. There are those who are unfortunate where the overzealous cut causes now a lot of irritation, and in that healing process, there's scarring that now doesn't move. Your soft palate is not moving well enough. So then you will have a problem with voice and others. But for majority of people whose uvulas have been removed, they go on to live a very full life.
Does your profession, your specialty cover tonsillitis?
Yes, absolutely. Actually, that's the mainstay management of ear, nose, and throat. Yeah, because of the incidence of tonsillitis.
To remove or not remove the tonsils?
We have very, very not even stringent, but very well clearly defined reasons for tonsil removal or tonsillectomy. One of which is if you have 7 or more episodes of tonsillitis, which means you have been okay, you have found a bout of tonsillitis, which is confirmed, what is called clinically. You were unwell, you had a sore throat, you had a fever, painful swallowing, and on examination, those tonsils were infected. You had to take a concoction of medications, including an antibiotic. 7 times. That is a real absolute indication for tonsil surgery. If you have 5 episodes of the same, each year of 2 years, then you require tonsil surgery. If you have 3 of the same each year for 3 years, then you require tonsil surgery. Now, most children will have a tonsillitis episode by their 5th birthday, but not all children will require tonsil surgery. So majority of tonsil problems that will therefore push you towards tonsil surgery exist in children. But we also remove tonsils in adults. I have removed tonsils in an 82-year-old lady who said she was finally brave enough to take the bold step, but she had been getting 7 episodes since she was 16. So I asked her, Sasa wewe.
7 episodes per year?
Yes, per year, including maybe a hospital admission once every 2 years. I asked her, why did you do it? She said, now I'm brave. I mean, why did you not do it before? She said, Sasa nimejikaza. So most common reason for tonsils removal is actually recurrence of infections. The other one is swellings within the tonsils, including also tonsil cancers, but very rare. Very, very rare.
What is it that would cause inflammation in the tonsils?
So first of all, tonsils are lymph organs. So they are part and parcel of our protection system. They help us in terms of immunity, and particularly so in the early years of life, up to the age of around 3 or 4, in which case other immune sort of organs, so to speak, take over that function. And that's why you find that if I take out the tonsils in a 3-year-old child, then I also have to tell the parent that do not be worried that their immunity will be a little lower than the children who they share a desk with, because they still have sort of similar immunity. Below that, I'll want to be careful and judge against the number of episodes of tonsil infection. So anyway, the tonsils have pockets, and those pockets can have food settling in them, and there are bacteria within our oral cavities. Some of us can have extra bacteria. Some of us can have things called biofilm. So you find in a household, you have 6 or 5 individuals, but there's one who is always coming down with tonsillitis, and the rest are okay. It might be that for that particular individual, there are those risks because of that, their tonsils. Either it could be that they're also big, and that's another reason for tonsil surgery, that you have such enlarged tonsils that occupy the space within the mouth and cause snoring and obstruction, speech and learning difficulty, dental issues. And so because of that risk in that particular individual, then you may need to consider treatment, which is surgery.
Snoring, sleep apnea.
Yeah.
What causes snoring?
That's one of the, again, that's one
Loud snoring.
Exactly.
Lorry.
Yeah. So we are not supposed to snore, even in our sleep, right?
We're not.
No, we're not supposed
Then
to.
why do we
Snoring
snore?
is unusual. But there are different kinds of snorers. So there are those who are even called habitual snorers. And it's interesting. You can say, baba zao, babu zao, walikuwa kingorota.
Wow.
But you want to, so in children, for example, especially below the age of 12, you should not notice snoring. So you should be careful. But the older we get, because of relaxation of muscles, tissues, and even maybe weight gain, many people will tend to snore as they grow older. But what you want to think about is, if somebody is snoring, do they also have a disruption in their sleep? In other words, you are not snoring so much before, but now this is a new thing and it's louder. And when they wake up in the morning, they feel tired. So meaning that you're not resting. So there is some level of oxygen being deprived in your sleep. If that is happening, then you need to seek help. And what causes snoring, now to further answer that question, is a narrowing. So if you have a good opening, you have what is called laminar flow. So air is passing through without obstruction, and therefore it's quiet. If you have a restriction of that airflow, then it will be loud because it becomes turbulent. And so therefore, if you want to think about snoring, it could be from the nose, it could be from the throat area. So you have to find out which part is obstructed and therefore deal with it.
Okay. A final question in about like 30 seconds, and this is from Carol. My daughter has been having recurrent inflammation of the parotitis gland. She's had an MRI, nothing has been picked, admitted twice under antibiotics. What's the issue?
So that's parotitis, and remember what we talked about, the parotid gland might be mumps. But if it's recurrent, you see, it's not mumps because that's self-limited. You get it once and that's it. If you're having a recurrence of parotitis, it could be that the gland system has a problem. It could be that the treatment that was given was inadequate in terms of duration and strength and choice of antibiotic. So I think if it has been recurrent, I would advise her to be seen by an ENT, and they'll be able to sort her out.
Many questions. Some are asking, how can we get in touch with you? Is it okay if we put your number and we share your number, or you can just say your number or where you can be reached?
Okay. Yeah, absolutely. So I run a clinic called Prodigy Ear, Nose and Throat Clinic in Upper Hill. Prodigy.
Right.
Ear, Nose and Throat Clinic in Upper Hill in KMA Center. And you're most welcome. We open every day except Sundays. And we're happy to see you.
Prodigy.
Prodigy.
Prodigy ENT. And you're most welcome. And feel free to share our contacts. And we are happy to help.
Asante sana.
Yes.
Thank you very much, Doc, for joining us today.
Asante sana.
That's Dr. Wahome Karanja. He's a consultant ENT surgeon. He's been here with us, just teaching us about the ear, nose, and throat conditions and how to keep them healthy.
This is the Situation Room, the only way to start your day.